We're taking care of some of the most needy individuals, the folks who are the most socioeconomically challenged, who have much higher medical needs. If they come from the hospital still needing hospital-level care, we're providing it. We weren't really awful, but we weren't really great either. We struggled all the time to try to figure out, why isn't this right? Why can't we do better?
Quality was always central, but it was not structured within the organization.
There was inconsistencies across the system homes and the processes and procedures that were addressing CMS 5-star quality measures.
The nursing homes were not performing really well in quality. We had a couple 1-star facilities, a couple 2-star facilities.
We knew that we had to take a hard look at ourselves to say, what do we need to change to make us better, to give our residents the quality of care they deserve, and we did that.
A facility may be scoring 2 stars in quality. Well, what does that mean? Traditionally, organizations feel this quality measures are clinically driven, but they're systematically driven. It's an approach as a whole to change quality. A lot of the data was about 6 months old to a year, and the systems were addressing retrospective actions and/or processes to address that data. The perspectives of physical therapy, OT therapy, the medical provider weren't introduced into the system. So when we used Lean Six Sigma and brought those individuals together in those departments, it was very clear and obvious that there was a disconnect between what was happening with the clinical interview. We then realized very quickly that it wasn't the interview that was driving whether or not someone was clinically in pain. It was the process.
We sat down as a division, we started developing processes based on each quality measure and developed best practices.
If we're looking at falls with major injury, what's the clinical driving force? Well, what's driving falls? Using data and Lean Six Sigma tools helped us identify through defining, well, the falls are really at this time. The falls are in association with this activity. Developing a plan that isn't just clinical driven. How do ancillary staff help within the facility to reduce falls?
I transitioned to this position in 2015, and at that time Unity Living Center was a 1-star. Since then, we've made significant gains in our quality measures, which led us to a 4-star rating. It's an everyday adventure. It's not once a day, once a year, once a month. You have to look at quality every day.
The big win here is we're predictive. CMS results come out about 6 months late. We are able to predict 6 months in advance.
Which means that our folks, right, are getting care sooner. They're getting better care faster. They're not hitting a quality measure down the road because they never get there. They don't get to being actually malnutrition because we're assessing them when they have the risk.
Every Monday, I pull the data in real time. It clearly identifies quickly which quality measures we need to hone in on that week and that day. When you see a health star aligning with the quality measure star, aligning with the overall star rating, then you can start to say, well, then your clinical outcomes are aligning with your quality measure outcomes.